pleasure to be here today and to kick off this session on blood culture management. I'm going to go over some of the basics, some of what I believe we know today that we've learned over the past several years about blood cultures. My disclosures are shown here on this slide. So this is real basics here. When we talk about blood cultures, we talk about a set of blood cultures, which is all of the bottles that are drawn with one venipuncture. And we talk about an order, which typically is 2 sets. We'll talk about that later on. You also see that in each of the sets here in the picture, there's an aerobic and anaerobic bottle, and we'll talk about the reasons for that as we go through this. Now, lots has changed about blood cultures over time. Some of the things that I was taught when I was training are no longer true. Timing of blood cultures is challenging. There's no perfect time because when a patient has bacteremia, there's an influx of bacteria into the blood, and that's followed subsequently by chills and fever. So it's hard to really find the perfect time to draw them. Also, some of you may have been taught, some of the older individuals, that you need to space out the collection of blood cultures, but that is no longer true as well because the microbiologic recovery of bacteria is the same for blood drawn simultaneously or at some sort of spaced intervals. And this makes it operationally much easier to do blood cultures. Volume of blood collected for blood cultures is very important. This is an old study from my institution from 50 years ago using manual blood culture systems showing that as you go from 1 set to 2 sets to actually 3 sets, you increase your yield of pathogens. And here's another study also from my institution, a little bit newer, only like 20 years old, that shows the same thing with continuous monitoring blood culture systems, that as you go from 1 set to 2 to 3, you increase your yield. Now, at my institution, we do things a little bit differently, and I'm not here to recommend that we do this, but for each set that we do, we draw 3 bottles, 2 aerobic and an anaerobic bottle, and we do this twice, so we have a total of 6 bottles. The reason for this is increased pathogen yield, and it may be somewhat specific to our practice at Mayo Clinic, but it has allowed us to look at what would happen if you dropped down to 4 bottles, what would happen if you dropped out the anaerobic bottles. And as you can see here, increasing the volume of blood clearly increases the detection of pathogens. And dropping the anaerobic bottles out of your blood culture collection, which is shown at the very bottom here, when we looked at what we recovered with just the aerobic bottles compared to, say, a comparison of an aerobic and anaerobic bottle, you also decrease the yield of pathogens. So those anaerobic bottles are very important for adult blood culture draws. Some other basics: collection of blood. So proper methods to prevent contamination are really important. Skin disinfection, ideally using dedicated phlebotomists rather than nurses and house staff to collect blood cultures. And of course, filling the bottles properly. I had dinner with a colleague the other night who transferred to a new institution. She's a pediatric infectious disease doctor, and she was just alarmed because the people collecting the blood there were taught think pink. In other words, you fill the bottles just enough to turn them pink. What a terrible recommendation. We need to fill the bottles properly to optimize the yield. And then, of course, this is simple. I know we're going to talk about a lot of advanced diagnostics today, but the blood culture bottles need to move from where they're drawn from the patient to the laboratory to the machine very expeditiously. When we looked at this in our own practice, there were huge opportunities for improvement. And of course, the bottles need to come off the machine when they're positive in a very expeditious way, ideally 24/7. And there's typically room for improvement there. Now, in 2024, a lot of us dealt with an unfortunate situation of the BD blood culture bottle shortage. But always when there are challenges, we have opportunities to learn. And we got to apply diagnostic stewardship in terms of blood culture management and look at how that impacted what we were doing with blood cultures. These are 3 studies that are from the literature. I'm sure there are more, and I'm sure some of you have experience as well, from 3 different institutions reporting what happened during the 2024 blood culture bottle shortage. What they all show is a decreased use of blood cultures, varying from 20 to 36%. And where reported, they show an increased positivity rate, suggesting that they dropped collecting the blood cultures that really were going to be negative in the first place. The strategies that were used vary. They include restricting blood cultures in the first place, and a lot of restriction of follow-on blood cultures for situations where they're not needed. You might need them, for example, for Staphylococcus aureus bacteremia follow-up, but not for many other situations where they're used. And then the way these were applied vary as well. Some institutions put hard stops in, like you cannot order this. Others put recommendations in, so there's a lot of variability. I really like this publication. It looks at clinical situations where blood cultures are low yield and not recommended, absent severe sepsis or septic shock. And you can see there are a lot of them. So lots of opportunities for diagnostic stewardship. Examples include isolated fever or leukocytosis without other findings of infection, postoperative fever, non-severe presentations of common infectious syndromes such as cellulitis, for example, surveillance blood cultures, fever or leukocytosis from non-infectious or viral etiologies, follow-up blood cultures, as I mentioned already, and other situations such as, for example, outpatient blood cultures. And I think, looking at these and seeing how to implement them in your practice can be very helpful. Now, I want to move on and talk about randomized controlled trials. You hear a lot about this, obviously, for therapeutics, a lot of exciting things at this meeting, but we can also use them for looking at diagnostics and for defining the value of diagnostics in terms of patient outcomes and antibiotic use. And you might wonder, why do this? The traditional way is a pre-post study where you look at what happens after you implement a new technology compared to the historical situation. The challenge with that is that it's hard to account for non-study variations over time. So our team has executed a number of randomized controlled trials of blood culture diagnostics that I'm going to share with you here. The first study we did, we're going way back to 2013, when the first BCID panel, this is not the one that's currently available, but the initial one was approved. And we really asked the question, should we implement this in our clinical practice? I'm sure a lot of you are asking that about a lot of novel diagnostics. And I would submit to you that this answer is already there, but this is how we approached it. So we executed a randomized controlled clinical trial. We randomized within the lab patients to have the older version of the BCID panel, or a standard of care. Standard of care is in green, the BCID panel's in blue, or they got the BCID panel with real-time antimicrobial stewardship. And then we asked questions about patient outcomes. We did not see any difference between the arms in terms of hard clinical outcomes like length of stay, mortality, readmission, toxicity, adverse drug reactions, or acquisition of drug-resistant organisms. But we did see differences, obviously, in time to identification and susceptibility results, and importantly, in antibiotic modifications. And specifically, what we saw is more rapid escalation of antibiotics. That's shown here in the E in the triangle with the use of the rapid multiplex PCR panel. Again, this is the original version of the BCID panel. And we saw more rapid de-escalation, that's the D in the upside down triangle, but only with a rapid test and real-time antimicrobial stewardship. So that we thought was really important. So overall, we learned that a rapid multiplex PCR panel performed on positive blood culture bottles led to more judicious antibiotic use, importantly without worsening clinical outcomes, more narrow spectrum use of antibiotics for gram-positives, less treatment of contaminants, less use of piperacillin tazobactam, and faster escalation and de-escalation of antibiotics, but only faster de-escalation in the context of pairing that with real-time stewardship. But we also noted that there was less benefit on the gram-negative side. Now, in this study, we spent a lot of time optimizing pre-analytic and post-analytic variables, like I mentioned earlier. We also looked carefully at reporting. This is what on the left comes off of that BCID panel. This is a BCID2, the more modern panel that I'm showing you here. This is what we actually report. What comes off of those panels is not very useful for clinicians. You really need to take those results and you need to translate them into what's going to be useful to your clinicians, especially since this is going out 24/7 when you may not have your highest level of experts in the laboratory. So for example, we'll tell them what organism and what resistance gene was detected, but we'll also tell them what that means, what they shouldn't be using, what they should be using, and other recommendations right in the microbiology lab report. Now, as I mentioned, one of the gaps in our study is that we didn't see a big effect on gram-negative bacteremia. And so then we turned to the question, what about rapid phenotypic susceptibility testing? In 2017, in the US, we had the first FDA clearance of a rapid phenotypic susceptibility testing platform. And so we executed this trial. This was sponsored by the Antibacterial Resistance Leadership Group of the NIH, as was the other trial that I told you about. And we did this at 2 sites in the US, and we randomized patients with gram-negative bacilli in their blood culture bottles to receive rapid phenotypic susceptibility testing or not. So we had a control arm shown in green on the left-hand side here, and then the rapid phenotypic susceptibility testing on the right, shown in red, and this was done with the Accelerate Pheno platform. And this is what it looks like. I'm not going to go over all the details here, but just to show you, this really looks like a therapeutic trial where you might be comparing drug A with drug B, but here we're comparing having this advanced diagnostic to standard of care. Now, we looked at outcomes with our primary outcome of time to first antibiotic change, and then secondary outcomes of patient-level outcomes. And this is what we found. We found that use of rapid phenotypic susceptibility testing led to a faster time to gram-negative antibiotic change. This was 25 hours faster. And when we looked at drug-resistant gram-negative bacteria, this was 43 hours faster with the rapid phenotypic susceptibility testing. However, in this study, as with the initial study I showed you, clinical outcomes, that is mortality, length of stay, readmission, transfer to the ICU, and acquisition of drug-resistant organisms, was not statistically significantly different between the 2 arms. So we concluded that rapid phenotypic susceptibility testing implemented with stewardship, we had stewardship in both arms in this study, can optimize treatment of gram-negative bacillus bloodstream infections, and we saw antibiotic modifications faster with the rapid phenotypic susceptibility testing than standard of care, 25 hours faster overall for gram-negative antibiotic changes, and 43 hours faster for drug-resistant organisms. One of the limitations, however, of this study is that it was carried out at sites with low rates of multi-drug resistant gram-negative bacilli. So we're executing another trial now. This again is with support from the Antibacterial Resistance Leadership Group of the NIH. It's called FAST. And here we're also looking at rapid phenotypic susceptibility testing. But the test we're looking at here is a Vitek Reveal platform that some of you may be familiar with. And our hypothesis is that rapid phenotypic susceptibility testing implemented with stewardship can optimize treatment and improve outcomes of gram-negative bloodstream infections. This is being done in areas that have higher rates of drug resistance than the other studies that I showed you. And so this is a big overview of the study. Our primary outcome is a desirability of outcome ranking, or DOR, at 30 days that looks at a number of what we call deleterious events that are listed here that I won't spend time reading to you. And then we're looking at secondary outcomes of mortality, length of stay, acquisition of drug-resistant organisms, and antibiotic modifications. This is being done at several sites in Europe, as well as Israel and India. And we're almost complete enrollment, so stay tuned for results of this clinical trial. So finally, in my last minute or two, I wanted to talk to you about this publication that came out in Clinical Infectious Diseases, also from the Antibacterial Resistance Leadership Group. We looked at the use of rapid diagnostics on positive blood culture bottles across the United States and some parts of Canada as well. And in our survey, we found that most labs are actually using them. We also were asked by the editors of Clinical Infectious Diseases to issue best practice recommendations. There's a lot here, and I encourage you to take a look at it, but a high-level summary is that laboratories should adopt rapid diagnostics for testing positive blood culture bottles. So I think that's really important. I think a lot of what I showed you is historic, has changed, and now the recommendation is to use them. But the selection of what you're going to do and how you're going to do it and how you're going to report that and how you're going to act on that should be done in concert with the clinical microbiology laboratory and whoever is making decisions about how antibiotics are used, your antibiotic stewardship folks or whatever the right term is at your institution for that. So I encourage you to take a look there. I'm going to wrap up. We're going to take questions, I believe, at the end. And thank you for your attention.